Have you ever, like, stopped to think what actually happens after you take a pill? Simple headache tablet, maybe.
Hmm.
How does it, get where it needs to go, do its thing, and then just vanish?
It feels automatic, doesn't it? But yeah, inside you, it's this incredibly complex dance unfolding.
Advance, I like that. Definitely not simple.
Not at all.
Yeah,
It's this constant back and forth between your body and that drug molecule. A conversation, really, shaped by physics, chemistry, your own biology.
exactly. And that whole complex conversation, that's what we're diving into today. We're
Yeah.
peeling back the layers on the basics, the fundamentals of how drugs work in the body.
Right. We've been looking at some foundational material about pharmacology, the kind of stuff that's essential for healthcare professionals, obviously, but honestly, pretty useful for anyone who takes medicine.
Yeah, definitely. So our mission here is to pull out those key ideas, those, aha
Hmm.
moments about what your body does to the drug.
That's pharmacokinetics.
Right, pharmacokinetics.
Yeah.
And then what the drug does to your body.
Pharmacodynamics.
Pharmacodynamics. Getting these concepts isn't just like academic theory. It's
Hmm.
really fundamental to understanding why medicines work, why they sometimes have side effects or don't work as expected, and how we make sure they're used safely.
Absolutely crucial.
Okay, so let's follow that drug's journey.
Mhm.
First big step, getting into your system, into the bloodstream, absorption.
Absorption, yeah, that's the first hurdle. And lots of things affect how well or how quickly that happens.
Like what?
Well, think about where it's being absorbed from. Your gut, maybe, for an oral pill. Blood flow there is huge. The better the blood supply.
The faster it gets picked up.
Exactly. Good circulation just whisks those drug molecules away into the bloodstream much faster.
So if someone has, say, poor circulation, that could slow things down.
It absolutely could, yeah. Another massive factor is surface area.
Like in the intestines.
Precisely. The small intestine is incredible. All those folds, the villi, if you spread it out, it's enormous. Huge surface area. That's why most oral drugs are absorbed there.
Okay, so anything affecting that surface area.
Or just how quickly the drug gets there can change absorption, like certain diseases or even just taking the drug with food.
Right. That explains why some meds say take on an empty stomach and others with food. Food can slow down stomach emptying, delay getting to that big absorption zone in the intestine.
Exactly. And think about antacids, too, like Gaviscon. They can coat the stomach lining.
Oh, so they could physically block or slow down absorption?
Yeah, potentially. It's why you often need to time them separately from other medications. And then there's the formulation itself.
You mean like capsules versus tablets? Or coated tablets?
Right. Some tablets have special coatings, maybe to protect the drug from stomach acid or to release it slowly over time. If you crush or split those,
Uh-oh.
yeah, you totally change how it's absorbed. You might get a big dump of the drug all at once, maybe causing side effects, or it might not work properly at all.
So rule of thumb,
Mm-hmm.
don't mess with the tablet unless you're told to.
Pretty much. Always best to check with a pharmacist or prescriber.
Okay. What about getting past things, like into the brain?
Ah, barriers. Yes, the body's got some really effective ones. The blood-brain barrier is a classic example, protecting your central nervous system.
And the placenta during pregnancy?
Then the placenta, yes. These are designed to be highly selective. For a drug to get across these barriers easily, it generally needs to be lipid soluble.
Meaning it dissolves in fats.
Right. Water-soluble drugs often just can't make it through easily. This is super important for drugs that need to act on the brain, or critically for considering risks during pregnancy.
Okay, absorbed. Influenced by blood flow, surface area, food, barriers. Now it's in the blood. Where does it go? How does it travel?
So now we're talking distribution. The drug travels mainly in your blood plasma, but it's not just floating around freely.
Some goes to specific places.
Exactly. Some tissues have a particular affinity for certain drugs, like iodine gets actively taken up by the thyroid gland, but a really key factor for many drugs is binding to plasma proteins.
Proteins in the blood, like albumin.
Albumin is the main one, yeah. Think of it like the drug molecules grabbing onto these proteins, they're temporarily parked.
So they're not active when they're bound.
Correct. Only the free drug, the portion not bound to protein, can actually leave the bloodstream, get into tissues, interact with targets, or be metabolized and excreted.
Okay, and I remember hearing this protein binding is particularly important in, like, older adults.
It really can be, yeah, a crucial clinical point. In older people or someone who's malnourished or has liver problems, their albumin levels might be lower.
Less protein to bind to.
Means more free drug circulating if it's a drug that normally binds heavily to protein. And that higher free concentration can significantly increase the risk of side effects or toxicity even at a standard dose.
Wow, so dose adjustments might be needed just because of lower protein levels?
Often, yes, it's a key part of geriatric prescribing. So distribution isn't just passive drifting, it's about where it goes, what it binds to, and those barriers again.
How can you tell if a drug is actually getting distributed correctly in a patient? Is it just watching for the effect?
Often, yeah, the clinical response is your main guide. You give a painkiller. Does the pain ease? That suggests the drug reached the target receptors. Monitoring that expected effect is how you gauge if distribution is happening as it should.
All right. Absorbed, distributed. What's the body's next step? Is it trying to get rid of it now?
It's starting the process, yeah. By changing its form. This is biotransformation or more commonly metabolism.
Changing the drug into something else.
Basically, yes. The body tries to convert the drug, usually into something more water-soluble, making it easier for the kidneys to eventually eliminate. And the main organ for this?
The liver.
The liver. It's the metabolic powerhouse.
So it just breaks the drug down into inactive bits.
Well, often, yes, into compounds called metabolites, but here's the twist. Metabolites aren't always inactive.
Oh.
They can be less active than the original drug, sure, but sometimes they're just as active, or occasionally even more active. Some can even have totally different effects.
You mentioned prodrugs earlier. Is that related?
Exactly. Codeine is the classic example. You take codeine, it gets metabolized by the liver into morphine.
Ah, and morphine is the strong pain reliever.
Right. So codeine itself is the prodrug. It needs that liver metabolism to become fully active. This whole metabolism thing also dictates dosing frequency.
How so?
If a drug is metabolized really quickly by the liver, it won't hang around long. You might need to take it, say, 4 times a day.
Where it's a slowly metabolized one.
Might only need a once daily dose because it sticks around longer before being broken down.
Okay. And what about that first pass thing? That sounds important for pills.
Hugely important. First pass metabolism. So when you swallow a pill and it's absorbed from your gut, the blood from there doesn't go straight into your general circulation.
Where does it go?
It goes through the portal vein directly to the liver first.
Before it gets anywhere else.
Pretty much. So if the liver is really, really good at metabolizing that specific drug, a huge chunk of it might get broken down on that first pass before it ever reaches the rest of the body.
Meaning very little active drug actually gets into circulation.
Exactly. Glyceryl trinitrate, GTN, for angina, it's almost completely wiped out by first pass metabolism if you swallow it.
Which is why you take it under the tongue or as a patch.
Right. To bypass that first trip through the liver and get absorbed directly into the general circulation, it shows how metabolism can dictate the entire way we give a drug.
Wow. Okay, so metabolism can activate drugs, inactivate them, change how often we take them, even how we take them. After all that, how does the body finally, get rid of the drug and its metabolites?
Last step. Excretion. Getting it out. The main route, the primary exit.
The kidneys.
The kidneys. Filtering the blood and putting the drug or its metabolites into the urine to be eliminated.
So kidney function must be absolutely critical then.
Oh, absolutely critical. If someone's kidneys aren't working well, maybe due to kidney disease, or just the natural decline in filtration rate, the GFR, that happens with age, or even dehydration.
The drug can build up.
Exactly. Drugs that rely on the kidneys for excretion can accumulate in the body, increasing the risk of toxicity. It's why checking kidney function is standard practice before prescribing many drugs, especially in older adults. A clinical tip here is monitoring fluid balance, too. Keeping well hydrated helps the kidneys do their job.
Are there other ways out besides the kidneys?
Yep. Some drugs or their metabolites are excreted into bile by the liver. Bile gets released into the intestines.
And then leaves in the feces.
Right. The combined oral contraceptive pill is an example that uses this route partly. And there's a really interesting phenomenon called enterohepatic recirculation.
Enterohepatic.
Gut.
Liver.
Yeah. Some drugs excreted in bile can actually get reabsorbed from the intestine back into the bloodstream.
So they go around again.
They do. It creates this cycle that can significantly prolong how long the drug stays in your system and keeps having an effect.
Okay, wow. That whole journey, absorption, distribution, metabolism, excretion, ADME, that's what your body does to the drug. So now let's flip the coin. What does the drug do to your body? Pharmacodynamics? How does it actually work?
Right. So pharmacodynamics is about the drug's effect. Drugs don't just randomly cause effects, they interact with specific molecular targets in your body,
Targets. Like what?
usually proteins.
Hmm.
And the most common targets are receptors, often found on the surface of cells.
Like little docking stations.
That's a good way to think of it. Receptors are like specific locks, molecules that bind to them, whether they're natural things your body makes, like hormones or drugs we introduce, are called ligands, the keys.
Okay.
And there are different types of receptors, different kinds of locks that work in different ways. Some open channels for ions really fast, others trigger slower cascades inside the cell, some even affect genes directly. But the basic idea is the drug binds to its specific target.
And then what? Does it turn something on or block something?
Exactly. That leads us to agonists and antagonists.
Right.
An agonist is a drug that binds to a receptor and activates it. It flips the switch, produces a response. It basically mimics or boosts what a natural substance would do there. We say it has positive efficacy.
Turns the key, opens the door.
Perfect analogy. An antagonist, though, binds to the same receptor, sits in the same lock.
But doesn't turn the key.
Exactly. It doesn't activate the receptor, it just occupies it, blocking other things, natural ligands or agonist drugs from binding and having an effect. It has zero efficacy itself. Its job is just to block.
Like naloxone for opioid overdose?
Classic example of a competitive antagonist. Naloxone competes with opioids for the opioid receptors. It binds more strongly or is present in higher amounts, kicks the opioid off, and reverses the overdose effects because the receptor is now blocked.
That agonist-antagonist difference is huge. But are drugs always super specific? Do they only hit the one target we want?
That would be ideal, but rarely happens. Specificity is a major challenge. Most drugs are designed for a primary target, but...
And they might hit other similar targets too.
Exactly. Very few drugs are perfectly selective. They might bind, maybe less strongly, but still bind to other related receptors or targets elsewhere in the body. And that's often where side effects come from.
Can you give an example?
Sure. Think about salbutamol, the asthma inhaler drug. Its main job is to hit beta-2 receptors in the lungs.
To open the airways.
Right, bronchodilation, that's the goal. But it can also interact a bit with beta-1 receptors, which are mostly found in the heart.
So that's why it can cause tremor or make your heart race sometimes.
Precisely. Those are side effects caused by the drug hitting a secondary unintended target because its specificity isn't perfect. It's a direct consequence of its pharmacodynamics.
Okay, so we've got ADME, the journey, and pharmacodynamics, the action. Let's tie this all together now with some real-world examples. How do these principles actually play out with different types of drugs and inpatient care?
Yeah, let's make it practical. Think about pain management. We mentioned receptors. Opioids, like morphine, are agonists at opioid receptors in your brain and spinal cord. They activate these receptors to block pain signals.
Okay, what about local anesthetics, like at the dentist?
Different mechanism entirely. They work by blocking sodium channels in nerve membranes.
So the nerve can't send the pain signal.
Exactly. They stop the electrical impulse right there. Pure pharmacodynamics.
And you mentioned fentanyl patches earlier. How does ADME play into that?
That's a great example of manipulating absorption for a specific need. Fentanyl is super potent. The patch allows it to be absorbed slowly, steadily through the skin over days.
For chronic pain, not acute pain.
Right. It avoids the ups and downs of pills. But that slow absorption also means you need careful education. Heat can make it absorb faster, which is dangerous, and metabolism is key for interactions. Some drugs block the liver enzymes that break down fentanyl.
Leading to toxic levels.
Potentially, yeah. Needs careful management. Or think about infectious diseases. Antibiotics are amazing because of their pharmacodynamic selectivity. They target things bacteria have that we don't.
Like their cell walls.
Exactly. Penicillins block cell wall building. Our cells don't have walls like that. Others, like gentamicin, mess with bacterial protein synthesis machinery, which is different enough from ours.
But sometimes there are side effects, so the selectivity isn't perfect.
Not always perfect, no. Gentamicin can harm ear and kidney cells related to how those cells handle the drug, distribution and excretion. Trimethoprim hits a bacterial enzyme well, but can slightly affect a similar human one, hence a rare risk of anemia. Cross-allergy between penicillin and cephalosporins happens because their structures are similar enough to trigger the same immune response.
What about antivirals?
They target virus-specific processes, like HIV drugs inhibiting the reverse transcriptase enzyme the virus needs to copy itself.
You mentioned nystatin earlier for thrush. How does that fit?
Perfect example of absorption dictating use. Nystatin works for oral thrush because it's barely absorbed from your gut.
So it stays in the mouth where the infection is.
Exactly. It acts locally without causing systemic issues because it doesn't really get into your bloodstream. Its lack of absorption is its advantage there. Moving to inflammation, steroids are broad-acting. They affect gene expression to dampen down lots of inflammatory pathways. Powerful stuff.
But lots of side effects, too.
Yeah, because they also affect metabolism widely, blood sugar, bone density, etc. NSAIDs, like ibuprofen, are a bit more targeted. They mainly block cyclooxygenase enzymes, COX enzymes, reducing inflammatory signals.
And those DRRs for things like rheumatoid arthritis, they sound complex.
They are disease-modifying anti-rheumatic drugs. They directly target the immune system. But this really highlights specificity issues and the need for monitoring. Methotrexate slows down rapidly dividing cells, good for calming the immune attack, but...
Also affects bone marrow, liver.
Right. Requires regular blood tests to watch for toxicity, and makes you more prone to infection. Hydroxychloroquine needs eye checks because of a rare risk to the retina. They often work slowly, but the potential side effects are significant, directly linked to their mechanism. Cardiovascular drugs, lots of different mechanisms. ACE inhibitors stop an enzyme that makes blood vessels constrict. Beta blockers slow the heart by blocking beta receptors there. Digoxin helps the heart contract more forcefully.
But I've heard digoxin can be tricky.
Very. It has a narrow therapeutic window. The dose that helps isn't far from the dose that harms, requires careful monitoring. And warfarin, the anticoagulant.
Ah, yes, the monitoring nightmare.
Well, it perfectly illustrates ADME challenges. Its effect on vitamin K is pharmacodynamic, but its metabolism is complex, handled by specific liver enzymes that vary between people and are affected by other drugs. And it binds heavily to plasma proteins distribution.
So tiny changes can have big effects on the active drug level.
Exactly. Hence the constant INR blood tests. Newer drugs like dabigatran often bypass these tricky metabolism and binding issues, making them more predictable, less monitoring needed.
What about diabetes meds?
Metformin mostly works on glucose production and insulin sensitivity, but watch out for lactic acidosis risk, especially if kidney function, excretion, is poor. Sulfonylureas stimulate the pancreas to release more insulin.
Yeah.
And insulin itself,
It has to be injected.
because it's a protein. Your gut would just digest it, metabolism, before it could be absorbed. The route is dictated by its nature. And briefly, neurology and mental health. Parkinson's. Levodopa gets converted to dopamine in the brain metabolism in the target organ. Antipsychotics often block dopamine receptors, good for symptoms, but blocking dopamine elsewhere, like the extrapyramidal system, causes those movement side effects. Lithium for bipolar.
A narrow therapeutic window again.
Extremely narrow. Needs close monitoring, patient education, treatment cards, and kidney function, excretion, is vital as it's cleared that way. Dehydration is a big risk. Even St. John's wort, the herbal remedy,
Can cause problems.
yeah, it can speed up liver enzymes, metabolism, making other drugs like birth control pills less effective. It's a significant interaction risk.
Wow. Okay, laying it out like that across different conditions really drives home how these ADME and pharmacodynamic principles are constantly at play, and how crucial the human element is, the patient, the healthcare team.
Absolutely. It all comes back to the patient and safe practice. Thinking about medication adherence, why someone might not take their meds, it's often tied to these principles. Are they having side effects? Pharmacodynamics. Is the formulation difficult? Absorption. Are there interactions? Do they even understand why they need it?
So clear communication and patient education are non-negotiable.
Fundamentally important. Explaining why a drug needs an empty stomach, absorption, or what side effect might occur and why pharmacodynamics, or why you need lots of water with isoclavir excretion, it empowers people.
Teaching someone proper inhaler technique is pure applied pharmacokinetics, getting the drug absorbed where it needs to be.
And for the professionals, constant vigilance and monitoring seem key. Totally. Spotting early signs of toxicity, like that tremor with lithium, or bleeding with warfarin. Checking kidney function before starting certain drugs. Recognizing unexpected side effects. Nurses, pharmacists, doctors, they're all applying these principles constantly. Understanding drug interactions, whether it's pharmacokinetic, like antacids blocking iron absorption, or pharmacodynamic, like a beta blocker fighting salbutamol, requires knowledge and checking resources.
And just getting the dose right in the first place.
Foundational. Drug calculations aren't just math. They're about ensuring the right concentration reaches the target safely. And the legal, ethical stuff, the 5 rights, while you generally don't crush tablets unless advised, it alters ADMAPD, becomes unlicensed use. It's all rooted in these safety principles. Even covert administration raises huge ethical flags tied to understanding and consent.
And learning when things do go wrong.
Critical. A no-blame culture for reporting errors isn't about letting people off the hook. It's about understanding the system and the pharmacology that might have contributed. Was it an interaction? A calculation slip? A misunderstanding of the drug's properties? Reporting helps everyone learn and improve safety.
So it's been quite the journey. We've traced how a drug gets absorbed, distributed, metabolized, excreted ADME, determining how much is where for how long.
And then how it actually interacts with our cells and systems pharmacodynamics to produce effects, both the ones we want and the ones we don't.
It really highlights just how much is going on under the surface. It's not just a simple pill. It's this incredibly complex interaction.
Absolutely. And it's so dynamic. It varies drug to drug, person to person, day to day even, based on physiology, other meds, food. Understanding these basics really is key to using medicines well.
Definitely. So thinking about all this complexity, how each of our bodies handles drugs just a little bit differently, it makes you wonder, doesn't it? Where does drug therapy go from here? Could we see treatments become even more personalized in the future, maybe tailored right down to our individual genes or real-time health status to boost the good effects and minimize the bad?
Precision medicine.
Yeah. What might that future look like, and what questions does this whole journey raise for you about the medications you encounter?